So thank you very much. Mohammed, and thank you very much, Andrew, for the invite. I would like to congratulate a new vision for the interesting webinar and all this to highlight all the different kind of application of the amniotic membrane. I think it's a very good tool that everyone should use it. So I will, as you can see from my title of my talk, I will explain the use of amniotic membrane in corneal perforation. The corneal perforation may results from various disorders, can be inflammatory, from infection, inflammation, trauma, or stromal melting. And the management is dependent from size, location, and etiology. Normally we tend to manage with the corneal glue or amniotic membrane transplant with the fresh amniotic membrane, or with the penetrating keratoplasty or tectonic graft. But tonight I would like to highlight that the use of a dry amniotic membrane is a good tool that you can use as a slit lamp, making your life easier and have very good results. So these will show that this slide show that this perforated high cornea is potentially devastating. So can have a persistent leakage that bring a shallow of the anterior chamber with the leakage of the humor aqueous, and have anterior synechia. You can develop after glaucoma. You can develop cataract after that, and in also endophthalmitis. So this is quite important. So you need to work on this. So you can't leave the patient without it, any treatment, but you need to act. And as quick you act, better it is. And here, again, I'd like to highlight that having this tool on the shelf, like the dry amniotic membrane, help you a lot to act quickly, probably in the best way. So just to highlight which are the patients that you want to know. If you have this kind of patient, the patient have a leakage, but the anterior chamber is stable, or is stable after applying a therapeutic contact lens, that is the patient that does not need a glue. This patient may be helpful to use a contact lens alone, or contact lens plus a dry amniotic membrane that you still have on the shelf. You can shape as you want the amniotic membrane, or you can put a little bit larger, doesn't matter. The matter is that you put a bandage contact lens, and the better if with the dry amniotic membrane. Instead, if you have a little bit large perforation that where there is an iris, as you can see, that is a plugging, or normally normally we used to use a lot the glue. As you can see, the technique also in the draw below. As you normally you take with the punch biopsy, take a sterile drape, and then on sterile drape from one side you put chloramphenicol, from the other side you put a drop of glue, and then you apply over the, let's say, over the hole. The question that is a temporary occlusion for a small or medium-sized perforation, but the drawback is to remain for only a limited time. Sometimes can detach before the cicatrization is complete, and have a little bit toxic, so it does not help the healing or reduce the scarring. Instead, I will show you now a video that shared by Sunita Charasia, that is a great surgeon. And as you can see, they use the amniotic membrane, as I said, as a graft. So you can put the stromal side on the perforation, you put a little bit of glue. This one needs to be done, as I said, you need to order the amniotic membrane, and you can do in the theater. As you can see, it's quite difficult. It's not possible to do at slit lamp, requires some skills, and but this is to show that a multi-layer amniotic membrane transplant is beneficial, because beneficial for the patient. The drawback, there is a contain growth factor, exactly, amniotic membrane, and help the healing, reduce the inflammation and the scarring. The drawback that you need to go in theater, you put some suture still, and this suture can let's say not help the astigmatism, let's say, or the shape of the cornea. I will show a different technique. So the technique that now we propose, but I think we use in the, I don't know if some other people use that already, but we find it quite useful. There are two ways. We try both, and we share the results after we show some patient that's been just published on Eye Journal. So the first technique is a multi-layer, where you can put your corneal perforation, as you can see in the draw on the top, and then you lie down a dry amniotic membrane of the shape that you like. The first thing that you need to do, you need to remove the epithelium around, in order that you have some good way to grip your, let's say, dry amniotic membrane. Then you can shape the other one, and you can apply with the forceps in the, let's say, in the hole, to do a multi-layer dry amniotic membrane. Then you put the glue that go a little bit higher, bigger, and then again in another amniotic membrane on the top. This is one technique. The other technique is that if it's smaller, you can apply straight away the glue, and then you use on the top the amniotic membrane. Why the amniotic membrane on the top in both cases? Why? Because sometimes it's easy to detach the glue. It's not smooth, so help you to avoid that is discomfortable, or help to avoid also that is moved too much. In addition to this, in both cases, we use a bandage contact lens. It's quite big diameter, between 20 and 22, and these help. I share with you the results. So this is a patient. You can see the color images on the top, and the patient before the perforation. Then you see the patient after the perforation with the corneal glue, amniotic membrane dry, and the bandage contact lens. And then this is the results later on after the color images. The C one is, I think, after 2 months, and was still holding there. Something that is very unusual for a glue to hold so much anyway. This patient, just to tell you the story, had a perforation that used the glue. The glue didn't hold the first time, and the second time, so this lodged after 3 days. The second time again did not hold, and the third time that I see the patient where we tried to do something different, and then we did something with the amniotic membrane, and worked quite well. I need to say, the multi-layer one, and I think it could be more a reason that you can you can give some substance, let's say, to the hole, and then hold also on the top. So in conclusion, the glue create, as I said, a raised irregular surface that can discomfort or dislodge the glue. The dry amniotic membrane is quite adaptable and used to adapt to the contour of the glue. A large bandage contact lens help the stability, and amniotic membrane provide an anti-inflammatory and antimicrobial properties, and it's very good and easy to teach, and can be used as a slit lamp. So that is my talk, and I would like again to thank you, Mohammed Al-Alfi, for the moderation, and Andrew for the invite. Thank you again.
Hello, everyone, and many thanks for inviting me to this webinar. Thank you, Mr. Al-Alfi, for the invitation, and New Vision. So today I will be presenting 2 papers, 2 of our techniques in East Kent hospitals. One is a case report recently been published, and the second is our preferred technique nowadays for pterygium surgery. both using the Omnigen amniotic membrane. As you know, my name is Nick. I'm based in East Kent. I'm a cornea consultant. I have no financial disclosures whatsoever. And let's start with the first case. Now, this is a 73-year-old man. He has ocular graft versus host disease. He has chronic myeloblastic leukemia, and he's on treatment for that. He presented to our cornea department with pain and photophobia in his left eye. He was already using preservative-free artificial tears, topical cyclosporine, and dexamethasone preservative-free eye drops. And looking at the slit lamp here, you can see a very marked paracentral corneal stromal thinning with epithelial defect. There is no active infection, no infiltrates to be seen, or anterior chamber inflammation. There was normal fundus. However, if you look at the anterior segmentosity, you can see how much the thinning is. We measured, I think, 148 microns at that point. So this is a cornea with a pending perforation. So instead of taking the patient to the operating theatre and performing surgery, we decided to perform a multi-layer amniotic membrane implant in the clinic. This is the technique. If you look at the anterior segmentosity here, we use 2 Omnigen grafts, one to fill in the gap and integrate to the corneal stroma, and a second Omnigen graft to cover the first graft. These were both 12 millimeter round Omnigen grafts. At the end of the procedure, we placed a large bandaged contact lens, 20 millimeter in diameter, to cover both grafts. The patient was commenced on cyclosporine, dexamethasone, chlorophenic eye drops, and was seen a week after surgery, 4 weeks after surgery, 2 and 3 months after the procedure. Looking at the results, there was marked clinical and structural improvement. This is, again, 1 week post-op, where you can see the multi-layer implant, and down here, 4 weeks post-op, where we can see a good integration of the amniotic membrane, but also increase in thickness of the epithelium, both on the stroma, about 230. Remember, the original thinning was about 140, now about 230, so again, almost 100 microns with this technique. The patient was happy, we were happy too. What are the advantages of this technique? First of all, it's a sutureless technique, and we didn't use any glue, and it's a quick procedure. It was done in the outpatient clinic, and we found that the patient responded very well. There was good integration of the Omnigen, and in this particular case, a pending perforation was avoided. So that's that from first paper. If you have any questions, please post them in our Q&A session. I'll be happy to answer them. Moving on to the second paper, this is about our sutureless technique for pterygium surgery. This technique has been developed in our department in the last couple of years, and we've treated almost 70 patients now very, very successfully. So looking at the technique again, we use topical anesthesia, of course, as per a normal technique, tetracaine and beta-lidocaine subconj. Then it's very important to dissect the conjunctiva down to bare sclera, a volus of pterygium, but also create a little pocket in the conjunctival tissue. Now, this is the pocket where we tuck in the amniotic membrane, the Omnigen. We use a large 20 by 20 millimeter graft, which is fitted in that area and tucked in under the conjunctiva. And at the end of the procedure, we use a large bandaged contact lens here in order to secure the Omnigen. The patients are given chlorophenic eye drops and preservative-free dexamethasone for about a month after surgery. Here's the video. So we start the surgery by marking the pterygium tail and head with a permanent marker. Then inject a little bit of lidocaine, 1%, under the conjunctiva, trying to separate the conjunctival tissue from the underlying Kinnon's capsule. That's very important. Then using Banner scissors, we will dissect conjunctival tissue and separate again from the Kinnon's capsule. As you can see here, one can also use a crescent blade to separate the pterygium, a bolus of pterygium, from the underlying corneal stroma and release any possible adhesions. A bit of pottery is applied to the bare sclera to stop the hemorrhaging of the major veins. And also very important to blunt dissect the conjunctiva and separate the conjunctiva. Here we're removing some of the tenuous tissue. It's very important that large removal of the tenuous tissue is done almost down to the rectus level. At this step, we will fit in the eye with the omnigen. It's a epithelial side down, a large 20 millimeter membrane, which is then being carefully. You can see that the left hand is lifting with equilibrium the conjunctival tissue, and then the right hand will just tuck in the omnigen under the conjunctival pocket. This is done in a very controlled manner. And we make sure also that at the end of this step, we have a little bit of omnigen tissue covering the epithelial defect of the cornea. And the last step, we fit the eye with a large 80 millimeter bandaged contact lens, which is then make sure there's no air underneath. And care is taken when removing the speculum. You need to be careful. You don't want the lens to fall out. So we do that very slowly, very controlled manner again. And by lifting up the speculum, the eye is padded then and doing conjunctival eye drops for 24 hours. And after that, just conjunctival dexamethasone eye drops. Now, this is the video, and our results were really, really good so far. We've treated, as I said, 63, but almost 70 patients now. Slit lamp examination was performed on day 3, 7, 1 month, and 6 months after the procedure. Here's a patient 1 week after surgery. What you can see is that the contact lens is still in situ. This is the edge of the contact lens, and also the omnigen is still in situ, covering all that important area. We only had 1 recurrence, so that's a very good recurrence rate in our series. And 1 patient where the BCL fell out. Surprisingly, even on that patient, and we saw this patient a week after surgery, the omnigen was still in place. And what's really important is that all patients were very comfortable with the recovery, especially the ones who had previous surgery with sutures or glue. They did say that this time it was much different, much more comfortable. So yeah, a successful technique in our hands. I must say, when I first, had the idea, and I was discussing this with Mr. Lamba about doing this technique, we didn't think that this will work. But after the first few cases, we just started doing it, and so far I decided to have really, really good results. What are the advantages? Again, it's a very simple technique. It's a very flat learning curve. It's a quick procedure. 15-minute procedure can be done in the operating theatre and the microscope. And again, we don't need to use sutures or glue, and that's saving time as well. So that's all for me. Thanks very much for watching. Hope you enjoyed it. And I'd like to give a special thanks to my cornea team at ECAF, Mr. Lamba, the other cornea consultant, Dr. Rice, our principal optometrist, and our 3 fellows, Mr. Ambapulu, Ms. Lavers, and Mr. Al-Zayadi, for their continued support in the last few years. Many thanks, and as I said, if there are any questions, please do feel free to post them in our Q&A area. Thank you.
Hello, everyone. Thank you, Mr. Alfi, for giving me the opportunity to present this work on this webinar. I'm Sundus Maqsood. I'm one of the corneal fellows currently at Queen Victoria Hospital and Maidstone Hospital. I am going to talk about amniotic membrane-derived dry matrix use in ocular surface disease. I would like to start with a declaration of interest, as my current work is based on a project which I'm doing with New Vision, and the grant has been provided from there. So I just want to declare it first here. Amnion application. We know that amniotic membrane has been widely used for various ocular surface disorders. Its first use was reported in 1910 when it was used for dermal tissues. In 1940, it was first used in ocular surface burn, and it was not till later in early 1990s it was started to be used much more widely. And within 20 years, we had more than 700 peer-reviewed publications on its use and outcomes. I'm just going to highlight here some of the uses which we have seen in literature for the use of amniotic membrane in ocular surface reconstruction, for persistent epithelial defects, and a bit controversial use in the amniotic membrane grafting for following pterygium excision. I will like to talk a little bit about the anatomy here of the amniotic membrane. As we know that it's the innermost layer of the amniotic sac. Structurally, it's made of an avascular stroma, a collagen layer, and a single layer of cuboidal epithelium, which makes it very pliable tissue to use on the surface of the eye for any ocular surface reconstruction procedures. Alongside that, it also have very useful components in the form of cytokines, interleukins, and some growth factors, which act as anti-angiogenic and anti-inflammatory properties. These are some of the functions which has been widely discussed in the literature. First is epithelialization, because it acts as a substrate to or basement membrane to provide the epithelial cells from the cornea to grow over it and act as a scaffold in this whole process. It has epidermal growth factors, keratinocyte growth factors, which help promote epithelialization as well. Anti-inflammatory, anti-angiogenic, and anti-scarring properties, with the presence of protease inhibitors, interleukin 10, and inhibition of beta transduction pathway. Antimicrobial properties has been also discussed in the literature, why the components like bactericidin, beta-lysine, lysozyme transferrin, and immunoglobulins this natural tissue possess. Since its wide use in 1990s, there are different ways of finding how to preserve the amniotic membrane in a way that it keeps all its good properties to provide the healing component to the ocular surface. The most commonly used preservation method is cryopreservation, which is done at minus 80 degrees with treatment of eagle medium and followed by dehydration. These are some photographs of ultrastructural changes that happens during the time of preservation. The top one is the fresh amnion, and the second one is the cryopreserved amnion. As you can see that there's much larger vacuoles in this sort of setting. And this section D is about amnion being dehydrated following cryopreservation. What I'm going to talk about in my presentation is using a amniotic membrane which has been preserved differently from our conventional method of cryopreservation, which is the dehydration method of vacuum dehydration following the treatment of the amniotic membrane with a lyoprotectant like trehalose or raffinose, which are sucrose molecules to help prevent the degradation that can happen during the process of this preservation. There are three ways amnion applications has been discussed in literature: the inlay transplantation, onlay, and a combinational technique. The inlay technique is when the graft acts as a replacement for lost tissue and is permanently incorporated and remodeled into the host tissue, whereas the patch transplant acts as a biological dressing to protect the wound and act as a physical barrier. And you can combine the two techniques together to provide these two properties on the surface of the eye when you are doing reconstruction. I'm going to talk about the management of persistent epithelial defects with OmniGen and OmniLens, and would like to thank all my colleagues who have worked on this project with me. This is a paper which we published in April 2021 in Clinical Ophthalmology about our outcomes, which is the largest pilot study on the management of persistent epithelial defect with amniotic membrane-derived dry matrix, that is OmniGen, supported by OmniLens. We reported the outcome of persistent epithelial defect in a retrospective analysis done at Queen Victoria Hospital as well as Maidstone Hospital. Our primary outcome measure included healing of persistent epithelial defects. We also looked at best corrected visual acuities afterwards, etiologies of these persistent epithelial defects, time to heal, and concomitant treatment during the process of healing, and number of applications per defect. So looking at the demographics, we had 86 patients which we recruited, and the number of defects we treated were 93. This signifies that the complex case mix of patients which we were treating, and number of them had, because of their background etiologies, they tend to develop multiple epithelial defects over a period of time. So every epithelial defect was treated as a new one. Number of applications were 107. More than 2/3 ended up having just one application of OmniGen and OmniLens, and less than a third require more than one application, with one patient requiring 4 OmniGen application per treatment per epithelial defect. The length of treatment for 22 days for overall patient group, and healed group, it was 25 days. Mean age of the patients were around 55 years, with male 60 in number and female 33. This is a list of concomitant treatments. Depending on their background etiologies, they were treated with antibiotics if they had microbial infections, and steroids with previous history of ocular surface inflammation. Some of them ended up having tarsorrhaphy as well, concomitantly, to improve the contact lens fit and to help improve the length of OmniGen application on the surface of the eye. This is a very busy slide looking at all the etiologies we looked at, which, as you can see, includes infection and microbial keratitis, patients developing persistent epithelial defects following corneal transplantations, and a large number of them were also limbal stem cell deficiency patients like Stevens-Johnson's, aniridia, chemical burns, herpes simplex keratitis, and neurotrophic keratopathy. So looking at our results, 58% showed complete healing, whereas 28% showed partial healing and 14% showed no response. Here I would like to define what was considered as complete healing and partial healing. Complete healing is related to the fact that the epithelium completely covered the epithelial defect which was present at the start of treatment, whereas partial healing is defined as reduce in the size of epithelial defect but inability of the amniotic membrane to completely let it cover with epithelium during the course of treatment. Looking at their best corrected vision, we had 59% of the patient reporting no change pre and post treatment, and 27% showing a better vision following the procedure. Only 15% showed some form of lesser visual potential afterwards. Looking at the infected case series, we had different etiologies of infective keratitis, including bacterial, fungal, herpetic, and an acanthamoeba keratitis treated with OmniGen and OmniLens for their persistent epithelial defects following initial treatment with fortified antibiotics and antivirals and antifungals. In the infected case series, we had 57% showing complete healing, 33% showing partial healing, and 9.5% showing no healing response. In post-graft group, similar results were there, 56% complete healing, 31% partial healing, and 13% no response. This is further subdivision depending on the type of grafts. In penetrating keratoplasty, as you can see, that we had 9 patients in total, and 6 out of 9 showed complete healing, whereas 2 showed partial healing. In the dark group, which we had 4 patients, we had 50-50% improvement and partial healing in this group. And in DSEC, we had 3 patients, and we had equivocal results. In neurotrophic disease, we had 75%, which is 3 out of 4 patients showed complete healing, and 1 patient showed partial healing. In limbal stem cell deficiency group, 50% showed complete healing and 27% showed partial healing. 23% showed no improvement. This is a chemical injury cohort where 60% showed complete healing and 20% showed partial healing. Similarly, limbal stem cell deficiency secondary to aniridia, we had 12 patients in the group. 7 of them showed complete healing, 1 partial healing, and 4 incomplete healing. In Stevens-Johnson's group, we had 58% showing partial healing, and 17% showed complete healing. This is just a case study showing how an OmniGen and OmniLens is applied on an eye with neurotrophic ulcer with rolled edges, as you can see, affecting the visual axis, and a complete healing being achieved at 2 weeks interval. So conclusion of the study was that it's easily applied without a storage restriction in the clinical setting, and its transparency allows easy visualization and examination of the cornea. The study overall showed safety and efficacy in treating persistent epithelial defects, and further larger studies would be beneficial to look at, especially our infective cases for further conclusions. In the next few slides, I will go through some exciting future projects we are planning to undertake using amniotic membrane-derived dry matrix. One of them is its use in ocular surface inflammation. We are currently running 1-year prospective audit, and it involves assessment of application of OmniGen in a plethora of inflammatory ophthalmic conditions, being effective at reducing the ocular surface inflammation. We are looking objective assessment of ocular surface inflammation and persistent epithelial defect with the help of a software and through photographic evidence, and of course looking at driving the epithelial wound healing as well. And visual acuity is also one of the outcomes we would be looking at. Like our previous pilot study, we are including all kind of acute or persistent epithelial defects which are resistant to conventional healing, infectious keratitis, patients receiving cross-linking leading to early haze, chemical injuries, Stevens-Johnson syndromes, dry eye disease, Sjogren syndrome. I'm going to show you some interesting photographs of a patient which we treated in last 2 or 3 months with ocular surface inflammation. This is a 40-year-old lady who presented with a contact lens related keratitis, treated for 3 weeks for tapering course of a dual therapy with fortified antibiotics, and was left with this central scarring along with aggressive vascularization of the cornea and a persistent epithelial defect. As you can see that with the help of this objective assessment and the help of this AOS software, we have managed to map these vessels as well as reliably measure the size of the epithelial defect to look at the rate of healing in these patients. And here you can see after 3 weeks of application, there is complete healing of the epithelial defect achieved with much reduced vascularization of the cornea, as confirmed by our analysis showing the vessels reducing from 31% to 28% at 2 weeks and 17% at 4 weeks. It would be good to objectively assess these patients and look at the anti-inflammatory properties, which has been widely published of this amniotic membrane. I'm happy to take any questions from here. Many thank you.
Thank you for that. And I want to ask about your the technique that you shown. You take a cannula, the rubber end, and use for applying the sterile drape disc.
So what I use, I take I put normally a speculum on the eye of the patient, a slit lamp, and I take a spear. And with this spear, I try to remove the epithelium that is loose around the perforation, let's say. After that I remove the epithelium, and the cornea is quite dry because it has a speculum plus with the spear I remove everything that is make a little bit wet, and then I will apply the amniotic membrane. After that, if the hole is quite deep, I apply multiple, and I cut in different way my amniotic membrane. And this is quite useful because it's quite easy to do. I can do with a forceps on the slit lamp, and then add one by one. Okay, and when I'm happy with that, I will put a glue. It's quite easy because the glue will go straight in position where I want. And the glue will be managed in a way that I put the glue on the top of the amniotic membrane, another amniotic membrane. So will be quite easy. Let's say instead to use the sterile patch, I use the amniotic membrane. So that said so, and then I will put the bandage contact lens. The results was quite good, and the patient was comfortable, and that's it.
Have you had to do one of these cases in theater using fibrin glue rather than cyanoacrylate?
Fibrin glue will be perfect and probably even better. Yes, if I have the chance, yes, I will do it. It's a little bit more challenge to do in clinic with the fibrin glue because it's not hold like the glue that we use for the cyanoacrylate, but it's possible. It probably will be better.
And the fact that your fibrin glue is going to dissolve probably quicker than the cyanoacrylate. So would you think with cyanoacrylate you'll have better results?
I don't think I will have better results internally. Probably I will have better results probably with the fibrin glue. This is my thinking, but I didn't use so far because I try to do a slit lamp and to act as quick as I can, and probably could be a good idea to try. But it's you need to order is a little bit more difficult and challenge for me to organize. But I will try after your suggestion. I will let you know.
Okay, our next question, I would start with you, Vito, and then I will ask Nick just to give his opinion as well. So have you used OmniLens in leg ophthalmos cases? And I would think this question relates to the exposure that can happen with the leg ophthalmos.
Yes, I didn't use in leg ophthalmos the OmniLens, but yes, I used the normal bandage contact lens, large diameter, yes.
But you haven't used amniotic membrane in cases of exposure keratopathy?
No.
Nick, any experience with that?
Yeah, not with leg ophthalmos, but I do use routinely OmniLens for exposure keratopathy patients with very good results. Obviously, leg ophthalmos is a more complex case because of the lack of lead motility. But one of the benefits of OmniLens is that its design is slightly thicker in the periphery, if I'm not wrong. So that acts like a suction sort of bandage contact lens. So whatever you put underneath, it just holds it in place. So that's my experience.
So having said that, have you ever encountered while putting the OmniLens having a big bubble of air underneath, and how would you overcome that?
Yeah, it's quite common, but it's not a problem. After an hour or so, the air will be gone. So that happens quite often.
Okay, then I have a question here about how long you have followed up the patients in the Pterygium study.
So in our study, we had a minimal follow-up of 6 months, but right now we have follow-ups over a year. Obviously, COVID was in the middle of the study. But really, really good results for most patients over a year now.
Well, the pterygium surgery is something that is common. It's done in every trust. So I would think that lots of surgeons would be thinking of adopting your technique. So you've been doing that for some time. You've showed a probably large amount of cases. So can you take us through just a few tips of what you have modified between the first case that you've done through to the last case that you've done?
Well, there's not much to modify. It's a very simple technique, as I said. And
anything that you would advise not to do, basically?
It's very important. To be honest, when we first had the idea about this, we didn't think it would work. We would say, okay, we'll try it, but it will probably fail. But then after a few cases, I guess our technique is a combination of the autologous blood technique published a few years ago. The difference is that when you do the autologous blood, you apply pressure. You have to apply pressure for about 10 minutes on the eye, whereas we just put a contact lens. It needs to be a large contact lens, obviously. And we also, the main trick is really to create a nice little pocket under the subconj, under the conjunctival tissue, and also do a very large tenotomy excision, the Timon's capsule. The last tip that I have is be very careful when removing the speculum at the end of surgery, because you don't want the whole thing just to pop out. And as I said, we did have one case where the contact lens fell out a few days after surgery, but surprisingly, the Omnigen was still there and did its work. So yeah, so far we're very pleased with our results.
And what about the multi-layers?
Yeah, the multi-layer was another thing. I mean, it happened in the clinic spontaneously, very, very similar to what Vito said, but instead of using glue, obviously that was a pending perforation, that wasn't an actual perforation, but there was a epithelial defect. It was a very thin cornea, and we used two grafts. The first to just fill in the gap as a multi-layer graft, and then as an inlay, essentially, and then a second graft to cover the first one, and then use the OmniLens to keep everything in place. And that worked really well too.
Okay, so the next question is about which side of the Omnigen.
Yeah, that's a good question. It's always the question, which side is it? So I think in my presentation, I've said for the pterygium technique, it's stromal side down. We usually say epithelial side up. So it's epithelial side up or stromal side down to promote epithelial growth over the Omnigen. That's how we were taught to do it, isn't it? Unless you use it as a multi-layer implant. So epithelial side up or stromal side down is our preferred technique for the pterygium.
And how easily does it stick without using glue or sutures?
Well, you'd be surprised how easy it is. You just have to try it. Obviously, having a little bit of blood under the contact lens does help because it coagulates. But as I said,
do you advise to leave it for a few minutes or?
No, we don't actually. What is important, we patch the eye for the first day or so. We put some chloramphenicol drops, not ointment, obviously. Patch the eye for 24 hours and then start treatment next day. And it just works probably because the Omnigen is so thin too. If you look at the studies, the previous studies, the autologous blood studies, they used conjunctival autografts, which is slightly thicker. And most studies would show that it's a very good technique with low recurrence rate, but there are problems with the fixation of the graft. So there was much higher risk of the graft, of losing the graft in the first few days with the autologous blood technique. Whereas if you have a contact lens, keeping everything in place, if you have a nice thin layer of amniotic membrane, it just works.
Very good. Yeah, Vito, please.
Can I add something? I think, I don't know how do you guys use the amniotic membrane and so the dry amniotic membrane, but I find very easy and useful to attach before the amniotic membrane and then to put the contact lens, because as you said, it's attached very well. Yeah. Normally in the beginning they try to put a bandage contact lens and the amniotic membrane on top and then the contact lens on the eye. But in this, if you do before the amniotic membrane, you can place where you want. It's very center where you like on the or on the area that you like, and then adjust after you put the bandage contact lens. I think in this way it's very difficult that is move. I don't know.
Okay.
Is it an experience that you have?
We use it directly on the cornea stroma, cornea defect. One important thing about the Omnigen, and that I learned with the years, because when I first used the Omnigen, I thought it was very brittle, easy to tear. It's very important to hydrate this membrane for a couple of minutes before using it. That makes a lot of difference, and it helps both with sticking on the cornea surface, but also to remain in one piece. So hydration of the Omnigen is very important for a couple of minutes, with BSS.
So Vito, in your conclusion, you mentioned about the anti-inflammatory properties for amniotic membrane. So do you have anything to share from your experience on a patient who had an inflamed ocular surface where you've used amniotic membrane and it has helped with the inflammation?
Yes, sometimes when the patient has some disease that you think, in any kind of patient that you think you would like to have some growth factor or something that can come, help the ocular surface, and you don't have anything immediately, I use the dry amniotic membrane, and I think helps a lot. Give you the good help in terms of growth factor and anti-inflammatory property that I want localized in that place, that probably pick up better than anything else. Because all the other arms or weapon that we have, they all take time. That you can use a fresh amniotic membrane. It's expensive, take time. The allogenic serum take much more time. I think the quicker way that we have is the dry amniotic membrane that is over the shelf and help the patient straight away.
As I can see, there is a question about healing of aniridia patients. And again, I will invite Vito and Nick just to give us an opinion. So if we can start with you, Nick. What's your opinion on aniridia patients who have persistent epithelial defects, and what do you usually do to manage this condition?
These are very complex cases. I prefer not to treat them in East Kent and refer them on to Moorfields. But if I had a patient with a epithelial defect, the Omnigen or any amniotic membrane can offer treatment, but temporarily. As I said, there is a stem cell deficiency, so those patients will probably benefit from a stem cell transplant or similar treatments in a tertiary center. So I prefer to not fully treat those patients. That's my experience.
And thank you, Nick. Vito, any experience with the aniridia cases, ocular surface problems?
I think Christine and Allied, this kind of patient has difficulties to healing, but there are different kind of patients that are more or less the same. Patients that have a limb stem cell deficiency or partial deficiency is quite difficult to heal. You need to try to give the best that you can, and again, this kind of a growth factor help you a lot. I use in this kind of patient, and they give you the help. Even also patient with the persistent epithelial defect, as you said before, patient after vitrectomy, that in diabetic patient that has difficult to heal. I know that they are difficult to heal. The epithelial rate, the healing rate of this patient is slower compared to the other, but it's as a temporary solution. Probably I will offer that.
And Sundus, what was your question?
Yes, my question was, Vito, you mentioned about you put a disc of Omnigen on top of the folded Omnigen you put for these perforated patients. My experience with Omnigen is that as soon as it touches the surface of the eye or anything wet, or even if I feel that there is a little bit of humidity within the air, it tends to shrivel down a little bit and stick to wherever it is. So using the disc of Omnigen and putting a glue in your experience, does it not make it hydrated and difficult to maneuver with the help of the tip of the spear to put on the eye on slit lamp?
No, you need to. I tell you, probably you misunderstood, or it was me that I didn't explain good enough. So you put a speculum. Then after the speculum, you put your amniotic membrane, one layer or multi-layer as you like, and then you put the glue, and then you put the
with a drape. Glue with a drape, the usual way.
I do, yes, but I don't use the drape. I use the glue. Sometimes you use also the glue even with this a needle, okay? Because I want to push not too much glue at all. So I use a very minimal amount of glue in the part that I need, and then I will use my things on the top.
Okay. I thought you use amniotic membrane disc as a
no. The disc that I cut with the amniotic membrane, then I use with the chloramphenicol like you used before, but without glue. So in this way, it's easy to go on it.
Oh, okay. Great, thank you.
Yeah, so Vito, just confirming, because John is asking, you use the cyanoacrylate glue in the clinic?
Say again?
It's the cyanoacrylate glue that you use? Yeah. And I think for the sake of time, we'll have this last question to Nick about your post-operative drop regime in pterygium surgery with your technique, and how long do you use the steroids for?
So typically, chloramphenicol, you use preservative-free 4 times a day for a couple of weeks, and then dexamethasone 6 times a day for the first week, tapering over a period of 4 weeks. And that does it. You don't need to use any painkillers, any dilating drops like with traditional tools in surgery, because it's just so comfortable. As I said, especially patients who had bilateral surgery, one I done with the conventional technique with sutures, and the other I done with our technique. They all came back and said that, look, this is so much better because they didn't have any irritation or inflammation, no foreign body sensation at all.
Well, thank you so much, and thank you all for the contribution. That's all what we have for the time allocated. Thanks for everybody for joining this evening, and thanks New Vision for facilitating this session. And